Okay,
thank
so we
you.
move on to the next speaker, or speakers who are with us online. It is Stefan Swartling Peterson, who is the former Global Chief of Health at UNICEF, now Health Specialist at UNICEF Sweden, and Professor of Global Transformations for Health at Karolinska Institutet. And we were to have Peter Wijswa, who is Associate Professor at Makerere University, also with us. But Stefan, he's not coming, or is he with us?
No, good morning. Peter had to, can you hear me?
We can hear you.
Peter, unfortunately, had to stay on in Boston. So it's 3 a.m. in Boston. So I promised him that I will take care of this and let him sleep. So I hope you don't mind.
We apologize him for that. Okay, we hear you well. So just continue, please.
Wonderful. Yes, thank you. I'm, as you heard, affiliated to Karolinska and UNICEF, but I'm presently a visiting professor at Makerere University, and I'm pleased to work with one of my teachers, Peter, and actually to hear my other teacher, Joy, online laying out the big picture here. And today I'm joining you from Kigali, where I'm actually in Norrsken House. You see me behind it, in innovation place where everyone is 30 years old, very beautiful, smart, driven, entrepreneurial, and innovating to save the world. A very exciting place to be. Now, the idea for today is about knowledge to practice, generating new knowledge and putting it into practice. And you heard the agenda laid out, and the idea was actually to give you a country snapshot of that from Uganda, which I've been a student of for the last 20 plus years. And Joy's point about research, I think is very fine and well made, because that is actually brings health systems, people like me, public health people like Peter, into the newborn field, and we need each other. So anyhow, how does this look like then at the country level? Well, this is recently new data from the Demographic and Health Survey, which came out in a month ago in Uganda, showing the mortality evolution in the last 25 years. And much of what I would been involved with has been the under 5 modality, acute febrile illness, malaria, pneumonia, diarrhea, community care. And you can see there's been a huge progress there, but the neonatal mortality over the 25 years has gone from 33 to 22. So that's much more of the flat line that Joy referred to. And then in addition, if you actually look at Joy's stillbirth paper, you'll see that Uganda's stillbirth rate is 21. So you need to double that. And a good proportion of those stillbirths are so-called fresh stillbirths that started the delivery process alive. So this is important, and it's one of the bigger causes of death in Uganda now, is actually in the newborn. Here is again Joy's slide that I borrowed, looking at the reduction in under 5 mortality in green and the newborn mortality in blue, and actually reaching 12. And what will that require going forward? Well, actually, Uganda is one of the countries that need to go twice as fast as it has been doing in the past. And then if you start adding fresh stillbirths, etc., maybe it will need to go 3 times faster. This is a very complex slide, which is essentially similar to some of what Joy showed you before. It's a WHO UNICEF joint publication from this year. And let's zoom in a bit on the top, because over on the left, you see things we love, things that we want to put in place, like KMC, like immediate breastfeeding, thermal care, all of those things that many, I think, of you are working with daily or researching on. And for me, I'm over on the right here together with Peter, thinking about where is the governance, the political leadership for this, the financing, the human resources. Are they there in numbers? Are they there in skills and competence? You heard about the infrastructure and the data system. So I wanted to illustrate some of these things that are required from the Ugandan perspective. This is again a 25-year picture for Uganda about the place of delivery. And when I came as a junior professional officer to the Ministry of Health, there was 61% home birth, 37% fertility. And I think 91% fertility delivery actually shows, to Joy's point, that we have the audience. The women are there, the babies are there. It's now up to us to deliver. So I borrowed here again Joyce boxes here about the phases where Uganda has been and where Uganda needs to go with the districts and special and sick newborn care units, and potentially where it might go in the future. But it's that phase 3 we're talking about now. And putting newborn units in every district is something I have a chance to look at in India and in Bangladesh, where it's happening, and much aided by this fantastic toolkit, which I really want to tell you to go and look at, the newborntoolkit.org. It's, to me, it's the state of the art in actually how to implement the package and turning knowledge to practice. So I cannot recommend it more. Now, I wanted to spend a little bit of time to illustrate some of the yellow things here. I had a chance to talk, showing most of these slides actually to the annual health sector review meeting in Uganda last week. And I learned that the human resources are there and approved in numbers now, but the recruitment ban is so far not allowing them to be actually recruited, although they are nominally there. The next level is, of course, the skills and the competence, because you need, and I don't need to tell you, to build that skills and competence. And how can we do that in big numbers quickly enough? Infrastructure, Joy talked about the floor plans and all of that, and obviously running out with growing populations of building new, remodeling is big. But let's talk now about financing and information systems. This slide Joy showed you, I just wanted to stress, and I showed it to the Ugandan audience saying, no, it's not just India and Bangladesh that can do this. Tanzania is now putting a newborn special care unit in every district, and they're financing it. And again, if you look at the right here, it's a $1 per capita investment across the population. That might seem not like a lot of money, but nevertheless, try getting 2.5% increase in the budget if you work at Karolinska Hospital or some other place. You know it's not easy. It takes arguments, and that's very much where Uganda is. So what does the healthcare spending look like in Uganda? Well, here's World Bank data showing what the per capita health spending, the top graph, has been and is over the last 25 years. And what you can see is that as we are asking for $1 more per capita, in fact, the healthcare spending has been going down over the last couple of years here. This is in part explained by COVID, by food prices, the economic recession, the war, post-COVID, but a lot of it actually is about numbers and growing populations. Because if you remember your middle school mathematics, it's good and well to have economic growth in the top, in the nominator, but the denominator, actually the population size, is going to erode whatever economic growth you have. And even if you spend an equal amount of money or an inflation-adjusted amount of money equal on the health sector every year, if your population grows 3%, the per capita spending goes down, which we see here. Now, what I learned last week now in the joint review mission is that Uganda is now getting universal health coverage, social insurance, national health service, if you will, which is going to be a mandatory contribution everyone will have to pay. Can this increase the funding base and actually bring in this more money? And the jury's out on that. The other element I learned, which I think is that, again, focus for research and improvement, is when money comes from abroad, global fund money, for instance, and other grant money. The absorption rate, the ability to spend and account for the money on time, is 67%. So 1/3 of the grant doesn't get spent, cannot be absorbed as it is. So what can you do to increase the financial absorption rate to be able to afford what Joy is talking about? Then I wanted to talk about context a bit. world is now 55% urbanized. Africa is slightly behind, but catching up very quickly. And by 2050, the world will be 70% urbanized. So it's no longer that rural hospital necessarily where these kids are delivered. It is in the urban setting, and many of these people, 1 billion people now, live in slums, and by 2030, 2 billion people will live in slums with poor infrastructure and access issues often. In these very rapidly growing mega cities across low and middle income countries, it's no longer just the public hospital. This is now the private clinic, it's the private school, it's a very mixed provision, both for health and for education. And people end up paying a lot for themselves for what they do. In Uganda, the so-called out-of-pocket expenditure for health that you pay yourself is 37% of the total health expenditure, which actually tells you that there's a good deal of money floating around in private facilities, in private care, and some of it buying missing things for the public care, where we don't know really which value for money we are getting. Is this good quality of care, and what can be improved, whether it's public or private, and how can we harness the private spending just through universal health coverage and insurance, but also what gets spent directly, how can we get better value for that? Then something on the information system. This is, I had the pleasure of working with Peter Weiswa across 6 hospitals in eastern Uganda over a period of 3 years, from 2013 to 2016, as you can see, to improve newborn care. And what you see here is a facility newborn mortality rate across those 6 hospitals over 3 years. And seemingly, it seems we spent 2 years killing babies, and killing babies more effectively, because the mortality rate, much as we were trying to do things, the green arrows down here, you see across the x-axis, the mortality rate was going up. It was seemingly only in the 3rd year that the facility newborn mortality rate started to go down. So what was going on here? We had money from Stefan Einhorn's Family Foundation, and we had a tough time explaining to Stefan Einhorn why we were spending his money by killing babies. But in fact, what we had to start by doing, and along the way, was to improve the data information system and actually capturing death and reducing misclassification between stillbirth and newborn death. That's why when you actually start doing something, it will appear, and I know Joy has this experience from other countries as well, apparently it appears as if you're killing babies, when in fact all of what you're doing is improving data systems. And that's why it's only in the 3rd year we were actually able, with better data systems and more effect of what we were doing, to actually show the decrease in facility and newborn mortality. Now, let's shift a little bit to the numbers of the population. And Uganda has a population pyramid in the true sense. I'm sure you're familiar with this. You have boys on the left, girls on the right, and you'll see that half the population here down at the bottom is less than 15 years of age, and that the birth rates are still increasing. The base is still broader. Yet there's this thing called the demographic dividend. When a majority of your population is working age between 15 and 65, you don't have many old people and you have few young, and that's when you can get rich, such as South Korea. And this is the South Korean population in 2005. And as you can see, the base of the pyramid is more narrow. It's no longer a pyramid, it's whatever this shape is. And reducing these numbers is important for your ability to invest in the young people, to invest in actually making health expenditure go up, to invest in healthcare, to invest in education, to have a productive workforce between 15 and 65 that can actually make your country richer and provide improvements across the country. Now, that's not the case in Uganda. And with a 3% population growth per year, you need 3% economic growth not to become poorer per capita. And you already saw some of the effects on health expenditure. It's a tremendous drain on infrastructure, the hospital. You need new schools every couple of years, etc. So what can we do here? Here's again the demographic and health survey showing on the right-hand figure here that the percent of demand for family planning that is satisfied by modern methods is 60%. That is, women who don't want more children, 60% are on modern family planning, but it means that there's an unmet need of 40%. And to me, this is a huge area and opportunity to improve newborn health and newborn survival, paradoxically, reduce the birth rates by closing the gap for unmet need. That seems to be one of the lower hanging fruits to improve newborn health. So what could be some of the agendas from a national perspective for newborn health? And Uganda now has just launched its new national community health strategy. So what can happen to prevent and promote, also using the community agents that we referred to in Joy's phases before? Well, again, I alluded to, and let me repeat it, let us actually reduce unwanted pregnancies. Let us reduce adolescent pregnancies and births. 1/5 of the births in Uganda are to adolescents. So that is children bearing children, 1/5, and that has not reduced. And in fact, COVID and school dropouts and poverty made that worse. We need to keep girls and yes, also boys in schools. One, because that reduces pregnancy rates, but ideally they should also be learning for the future. And you may be familiar with the learning crisis. Many go to school, don't know how to read and write. 7 out of 10-year-olds in the world don't know how to read and understand the simple text now. So going to school may be fine, it may prevent pregnancies, but ideally you should be learning. We need to support early brain development through community agents, through preschool, through stimulation, through playing with children, because it's not just about survival, it's about thriving and it's becoming a productive member of society. And then I would say we need to promote good diet. And of course, for the newborn, that is breastfeeding immediate, it's good supplementary feeding. But my point is also here that this is in the mother as well. This is in men and women as Africa goes through the nutrition transition. Overweight, diabetes are really becoming, pardon the expression, epidemic. And a good number of the stillbirths are actually explained by diabetes and hypertension and other things that actually have some of their roots in the diet and the nutrition transition. So on WeShare, on research, we need a nutritionist as well. Now, then there is the aspect around what should go on inside the facility, because as Joy said, we need quality care as well. And I think I've illustrated from a Ugandan perspective now that we need health system support. We need more money. We need better financing mechanisms. We need research into collecting tax more effectively. We need research on increasing absorption rates for grants, etc. Yes, human resources, how can they be trained to actually have the competence and the skills as well? I alluded to the data systems challenge, infrastructure when your population grows, what should it look like, how can it be built, etc. And then given the mixed provision systems, the public and the private, the ingredients may be there, but how do we put it together? How can we do on the minimum quality control and better quality improvement in a decentralized system with 37 districts or something that Uganda has now, and across public as well as private providers. So we need our quality improvement and implementation science colleagues here. And then finally, I would like to say that much as we are all talking about offering better care on the supply side, if you will, we need to strengthen the demand side. We need mechanisms for social accountability, whereby people can say that the healthcare I'm getting is not good, the delivery care is not good, the education my kids are getting is not good, without them having to step forward as poor individuals and challenging important healthcare providers and teachers. Here is an innovation I think we need from some of our digital friends. Can we have digital scorecards, etc.? And there are good examples. And Martina Björkman Nyqvist at Handelshögskolan did a lot of pioneering work on strengthening social accountability through data and dialogue, improving mortality much more than most of us in health sector never do. And so I wanted to leave you with a reading tip, being a professor, because I want us to think certainly about healthcare. I want us to talk about health systems, but increasingly to think about systems for health, where we need everyone, the we search, and all the sectors to come together to produce health, because health is much wider than healthcare. Please download this from the Alliance. You will just Google it and get it. And that's what I wanted to share with you today. And I would have liked to have a discussion with Peter Weiswa, but anyhow, you'll have to do with me.
So I think we have time for at least one question for Professor Stefan, if there is anyone in the audience or anything online. I'm taking the opportunity then to ask. I was curious about the fact that you found when you started to really measure the numbers of stillbirths, then you found that some of them were maybe actually live but died early. That's how I interpreted it. How?
Yes.
Do you think that is a common problem, and how would you be able to just make a rough estimate? How many do you think of this great number of stillbirths that are maybe not real fresh stillbirths but born alive and then died?
You know, I will not dare to guess that, particularly not with Joy Lawn listening. On the other hand, the misclassification between live birth and stillbirth I've seen across a number of countries, including Eastern Europe and former Soviet Union, Central Asia, etc., because there are many incentives for that, right? Saying that, no, it's not Morten's fault that this kid was born dead, right? As opposed to saying the baby came out, had weak signs of life, and we failed to resuscitate the baby. So I think we should think incentives there and trying to figure out and not penalizing health workers in that situation and building that confidence and the trust through audits and others. Over.
I understand. Thank you so much, Stefan. Yeah. Okay, there was another question.
Hi, Stefan. It's Nicholas. Thanks for your talk. Why wouldn't the larger numbers of deliveries in facilities have a direct impact on better outcome? Why do we see this dramatic change and virtually no change during a 10-year period where more babies are born in facilities?
Well, I think we have seen a 1/3 reduction, as you saw, 33 to 22. That's a 1/3 reduction. Meanwhile, the under 5 mortality went down by 2/3. So yes, there is improvement, but I think, and what I'm learning from Joy, is that there's so much you can do through basic public health measures and hygiene and facility delivery. But unless you have the special newborn care units supported by KMC on top of that, you're not really going to take the next step in mortality. And in Uganda, those have not existed. They are now building 25 of them across 137 districts, which is a nice first step. So yes, it's about taking that next step in infrastructure with all of what it takes. And I had the chance in my UNICEF days to visit northern Ghana and a district hospital, which had received one of those special newborn care units. And I asked the medical superintendent, well, how much staff does it take to run this thing? Because UNICEF had equipped it and set it up and remodeled and all of those nice. And he's like, 24, 8 people times 3 shifts. And obviously, this is a tremendous shift we're requiring of health systems and burden district hospitals. Even if we fix the infrastructure, even if we send a machine, etc., where are the staff going to come from and the running costs? So it is a big systems issue that is required to take the next step. That's my answer.
Thank you. Now we have to move on to the next point in our program. We will